Hello, and welcome to the ACR Journals on Air podcast. I'm your guest host, Parth Kumar, filling in for Vicky Shamagan. One of the great joys of being a rheumatologist is that we encounter a tremendous variety of conditions. And due to advances in science and technology, our understanding of these conditions is rapidly evolving. Sometimes, rarely, but more and more often nowadays, what we thought was one sort of disease with one sort of presentation becomes another disease with many more manifestations. Today, we'll be talking about one such condition undergoing such a rapid evolution, giant cell arteritis. In particular, we will be reviewing this manuscript, Ultrasound Compared to Computed Tomography in Identifying Thoracic Aortic Aneurysms in Patients with Giant Cell Arteritis. It was published in Arthritis Care and Research, and a link to the manuscript and disclosures are in our show notes for today. We are so grateful to be joined by the first author of this study, Dr. Bull Haaversen. Bull Haaversen, MD, is a rheumatologist at Martina Hansen Hospital, Norway, and is a PhD candidate at the University of Oslo. Her PhD work, currently under evaluation, explores the utility of vascular ultrasound in the diagnosis and follow-up of patients with giant cell arteritis, or GCA. She has a particular clinical and research interest in GCA and vascular imaging, and much of her daily practice involves caring for patients with this condition. Through her work, she aims to integrate vascular ultrasound as a practical and accessible tool for improving patient follow-up and long-term outcomes. So, welcome, Dr. Haaversen.
Thank you very much, and thanks a lot for the invitation here. It's a pleasure to be here. And I'm looking forward to share some of our work on GCA patients and ultrasound, and especially on this work on aortic involvement in GCA.
I am extraordinarily excited about this. I love ultrasound so very, very much. But before we go into the ultrasound, could you tell us a little bit about giant cell arteritis? For a long time, it had been synonymous with temporal arteritis, but is this truly accurate?
Yeah, that's. I'm very glad that you asked this question, because the term temporal arteritis, that is not precise. This term, temporal arteritis, this simply means inflammation in the temporal artery, and that can have many causes. For example, infections or other vasculitis. So temporal arteritis is not a diagnosis in itself. So as you say, historically, GCA was called temporal arteritis because the temporal arteries are superficial and they are easy to examine and biopsy. So they were the vessels clinicians could actually see and feel. And I think therefore the vessels define the disease. And typical symptoms are headache, scalp tenderness, and visual symptoms due to inflammation in these arteries. But with the introduction of modern imaging, like PET-CT, MRI, CT, and ultrasound, and also from older autopsy studies, we now know that the disease GCA actually extends far beyond the temporal artery. In fact, the aorta and its major branches are frequently involved. So this has shifted our understanding from a localized cranial disease to a true large vessel vasculitis. So giant cell arteritis is a systemic large vessel vasculitis that affects people over the age of 50. And the name giant cell arteritis comes from the characteristic granulomatous inflammation seen on histology, where multinucleated giant cells may appear in the vessel wall. And I would also like to mention that today we often speak about 3 clinical patterns, depending on which vessels are involved. It's the cranial GCA, with the cranial or the temporal arteries that are inflamed. And it's the large vessel GCA, and a mixed form where both cranial and large vessels are involved. And the disease can cause serious complications. And the one most known and talked about, I think, is visual loss. And some patients actually can present with the visual loss as a symptom. And another serious complication is aortic dilatation and aneurysm. And these are feared complications that we, of course, struggle as doctors to prevent or avoid, of course.
Yeah, so as you mentioned, among these manifestations of GCA are these aortic aneurysms, especially with the large vessel pattern. How common are these aortic changes or these aneurysms? Where do they tend to occur? And are there any other patterns in terms of their prevalence?
Yes, the aortic aneurysms are important complication of giant cell arteritis. And if you look across the literature, the pooled prevalence for thoracic aortic aneurysms is around 15%. But the estimates vary. They vary a lot because the studies, they are often retrospective and they use different definitions and there are different imaging strategies. But what's consistent, though, is that patients with GCA, they have a markedly high risk of thoracic aortic aneurysms compared with the general population. And there are several patterns that stand out. First, the increased risk is in the ascending part of the thoracic aorta and not in the abdominal part. I'm not really sure why it's so, but it's likely related to the biomechanics of the vessel, where the ascending aorta is directly exposed to pulsative stress from the left ventricle, and the wall structure is in this segment is more vulnerable to injury. And second, the aneurysm, they usually develop years after the initial diagnosis. So they are considered a late structural complication where the risk increases over time. And the third, as you mentioned, patients with involvement of the large vessels, they appear to be in the highest risk. So in the prospective part of our study, all the patients who developed new aneurysms had large vessel involvement. So just to summarize this answer, the ascending aorta is the key location. The complication tends to arise late in the disease course, and large vessel involvement seems to be an important risk factor.
I love the summary that you've given over that. And I really hope that there are fellows that are listening because this is a great 5-minute introduction, let's say, to giant cell arteritis. I wanted to ask you a little bit. So, your investigation looked specifically at ultrasonography as a means to identify and monitor these aneurysms compared to CT scan, of course. Going into the study, why did you and your co investigators want to compare ultrasound to these other imaging modalities?
Yes, I think in different settings in rheumatology, there is always an ongoing discussion, and also in my hospital in daily practice, about how we should follow these patients over time, which imaging modality is most appropriate, and when, how often to monitor them. X-ray has low sensitivity for aortic disease. CT could be excellent, but it involves radiation, often contrast, time consuming, it can be expensive. So it's not ideal for repeated long-term follow-up. And in Norway, in rheumatology, we use a lot of ultrasound in daily practice. It's like we have an ultrasound machine in almost every office in my department, so it's easy accessible. And yes, it is inexpensive when you have the machine, and it can be performed without any risk for the patient. So yes, we in Norway and Europe also, ultrasound is already well established as a first-line diagnostic tool in GCA. But for follow-up, the situation is much less clear. We do not have established guidelines on how often to image these patients, and there is very little evidence on whether ultrasound could reliably measure the ascending aorta in this context. So, in fact, before our study, I don't think anyone had directly compared ultrasound with CT for this purpose in GCA. So our aim was to fill this evidence gap and answer a very practical clinical question. Can ultrasound provide reliable measurements of the ascending aorta during long-term follow-up? and potentially reduce the need for repeated CT scans.
So I am incredibly jealous to hear that every
Yeah.
clinic room has an ultrasound in Norway. And I certainly hope that in the United States we will catch that in the near future. I hope. This is an audio podcast, and it's so hard to demonstrate this, but I'm very curious. How do you measure the size of an ascending aorta?
Yes, in practical terms, measuring the ascending aorta with ultrasound is quite straightforward. We place the patient in the left lateral position and use a parasternal long axis view. It's just like in standard echocardiography. From this view, we can usually see the proximal ascending aorta very clearly, and we measure the widest visible part of it. It's usually about 1 to 3 centimeters above the sinotubular junction. We use an inner edge to inner edge measurement, and in our study, we did it simple, and we didn't standardize into the cardiac cycle. We measured the diameter where we had the most clearly view, and we measured at the widest part that we could see. And in most patients, I think this window is easy to obtain. So, which is why ultrasound can be a very practical method for monitoring changes over time.
Absolutely love to hear those kind of details. And I regret that we don't have accompanying video to show where exactly you would place an ultrasound probe. But I will take your word for it that it's fairly straightforward. I wanted to get to the meat of the investigation. Can you tell us how your study was designed? How did you go about investigating your aims that you had mentioned earlier? And what were the variables that you were looking at?
Our study actually had two separate parts because we were trying to answer two different questions. So the main part, the first, asked, can ultrasound and CT give comparable measurements of the ascending aorta in GCA patients? So to answer this, we did a cross-sectional study where the patients had both ultrasound and CT of the ascending aorta within a 6-month window. And we then compared the two measurements directly. And for the second part, we wanted to see how many patients developed aneurysms over time. And for that, we used a prospective design. We included patients who had baseline aortic imaging at their diagnosis. And then we repeated the imaging at last follow-up. So this allowed us to follow the diameter over the disease course and detect new aneurysm formation. And also for the cross-sectional part, the first part of the study, we used multivariable logistic regression to identify factors associated with having an enlarged ascending aorta. So the variables we included were sex, age, large vessel involvement, and GCA subtype. It would be very important to find out more about if there are certain patient characteristics that might predict who is at high risk. Yeah, but for the prospective part, the sample size was too small to look at those factors.
It's too bad to hear that the sample size was a little too small. Just by my own eyeballing, there were about 140 patients and 169 comparable E and ultrasound scans. That seemed like a lot, but obviously, when you do the math, it becomes very different sometimes. Can you tell us briefly what were the results of your investigation? Did anything surprise you when you completed your data analysis?
Yes, there were several aspects that surprised me. For the first part, the cross-sectional part where we compared ultrasound with CT, the agreement between the two methods, it was strong and even stronger than I expected. I mean, anyone who performs echocardiographic measurements knows that small variations, if you place the caliper here or with only some millimeters difference, that can influence the result a little bit. But despite this, ultrasound and CT correlated very closely. So this suggests that ultrasound can provide reproducible measurements when used in a standardized way. And the second surprising finding was the number of patients with aneurysmal dilatation. In the cross-sectional cohort, about 1/4 of the patients met the definition of an ascending aortic aneurysm. That felt like a high number, even though we know from the literature that thoracic aneurysms are common. But just seeing it so clearly in our own material was still striking. And this was also the true for the prospective cohort, where nearly 1 in 5 developed a new ascending aortic aneurysm. And that was during a mean follow-up time of almost 5 years. And it was one thing more I want to mention that was a bit surprising, because of the 50 patients who had baseline aortic imaging, there were 10 of these that had an aneurysm already at diagnosis. That itself is a notable number, but we usually think of aneurysm as a late complication in GCA, as I told earlier, developing after years. So seeing this at baseline was quite surprising. But again, the numbers are small and should be interpreted with caution.
All of these things are super fascinating to me. I had a few things that caught my fancy when I was looking through the article. And I don't know if you have any thoughts about this, but one thing was that it seemed like men were more likely to have these aortic dilatations. Why do you suppose that's the case for men?
Yeah, the men had a bit lower, 4 times higher odds of aneurysm than women, even after adjusting for age, the GCA subtype, and if the large vessels were involved. But I think we can only speculate about that. Men in general, they tend to have larger aortic diameters, and they have a higher burden of traditional cardiovascular risk factors. There may also be sex-related difference in vascular remodeling. So, we can only speculate.
Well, those are some very interesting potential research directions, right? Especially since ultrasound seems to be a pretty reliable method of identifying these. I also thought it was really interesting how isolated descending aortic aneurysms were really rare. Any thoughts about that? Or am I reading it correctly even?
Yes, you're right. The patients with descending aneurysm, they tend to also have aneurysm or dilatations in the ascending part of the aorta. So you're right. It seems like having in one part of the thoracic aorta, you also have in other segments, and the ascending part is the most common. So we think that visualizing this part is enough. Is how to say that it is sufficient.
And it seems especially important given that the amount of people with aortic aneurysms at baseline was so high. That really sounds like that's a major headline from your study. I was also really glad to hear that it sounded like ultrasound was pretty reliable, because one of the common criticisms about ultrasonography is that it's highly operator dependent. Do you have any other comments about that? I mean, I was really heartened by that, but I do feel like in my practice, as you mentioned, if you just move the probe just here or there, you'll get some wide ranging measures.
Yeah, the operator dependency is always something people bring up with ultrasound, and it's a fair point. But like every imaging method, there are some degree of operator dependency. So that's not only with ultrasound. For example, interpreting CT scans also depends on the person describing them. So yes, ultrasound is a method that depends on experience, and you need training to get reproducible measurements. In our study, the scans were done by ultrasonographers with a lot of experience. So that probably contributed to the strong agreement we saw between ultrasound and CT. And in addition, we had a specific training that was provided in collaboration with a cardiologist. So I think in our material, operator dependency didn't seem to weaken the results in any major way.
Well, that's great to hear, and it does highlight the importance of good education and interdisciplinary collaboration. You started to mention this a little bit earlier. I'm curious about the limitations of your study. So, all of these are very exciting, but like all studies, there are obvious limitations to the studies. What are some limitations that you think readers and listeners should be aware of?
There are some limitations to be aware, of course, and some of them they just reflect the reality of doing clinical research in a real world setting like our study. So first, the CT scans, they were routine clinical scans. So they were done at different hospitals with different protocols, and some with and some without contrast. So that absolutely creates some variability. We tried to address some of this by doing a sub-analysis where we compared contrast and non-contrast CT, and the difference in diameter was very small. That also fits well with the literature showing that contrast is not essential when you only measure aortic caliber. And second, as we already have spoken a bit about, the ultrasound being operator dependent, we didn't formally measure the inter-observer variability for the ultrasound examinations. But as I said, we were quite experienced and we had that structured training program. And finally, especially the prospective part of this study had a relatively small sample size. So the results should be interpreted with some caution. But overall, despite these real-life limitations, so to say, the agreement between ultrasound and CT was strong and the findings were consistent.
That's a very bold headline. So that's wonderful to hear. How do you think your results will impact policies and potential future guidelines for the diagnosis and the management of GCA?
Yeah, I think our results highlight some areas that future guidelines may need to consider. First, as we already have talked about, the surprisingly high proportion already having an ascending aortic aneurysm at baseline. This suggests that aortic changes may be present already at the diagnosis. So, yeah, first it would be interesting to look at this in larger cohorts, but that could matter. And the main point concerns follow-up. It is already well known that thoracic aortic aneurysms they can occur in GCA. So our data are a real-world illustration that in the prospective cohort, almost 1 in 5 developed this aneurysm. So this aligns with the existing literature and reinforces the need for structured monitoring over time, especially in patients with large vessel involvement. So I don't think our study changes guidelines on its own, but it adds to the growing evidence that this aortic assessment should be part of long-term management in GCA. Our results supports ultrasound as a possible follow-up tool within this framework. So, we hope that ultrasound can be integrated as a part of the longitudinal monitoring strategy for GCA patients.
Certainly, I hope so too. After reading your article, I really was taken aback by how common these aortic aneurysms were. And so, in my own practice, I definitely will be more on the lookout for these aortic aneurysms through clinical examinations and probably through CT scans. I don't think that I'm quite acquaintance. I don't have a good acquaintance with echocardiography quite yet for these. I am incredibly curious about this. So, on a larger longitudinal scale, it sounds like you have published a lot about ultrasonography of large vessels in giant cell arteritis. Tell us, how did this become a major focus of your research?
Yeah, for me, this focus developed very naturally in clinical practice at my department. I saw a lot of GCA patients. It's quite common disease in Norway. So I was introduced to vascular ultrasound by my colleague Andreas Diamantopoulos, who later became my PhD supervisor. So it quickly became clear to me how useful ultrasound could be for diagnosing these patients, and that an extended examination identified more large vessel involvement. And I also saw how many unanswered questions there were about follow-up and long-term complications. So we started to collect the data systematically and built a cohort where the patients were examined by ultrasound at every visit, both to understand the diagnostic side better and then also to look at relapse assessment and aortic involvement. And at some point, it was clear that this had become a full research project. So that is really how it developed into a PhD directly from the clinical work, the patients we were seeing, and the practical challenges we wanted to solve or look more at.
And I am so glad that you are able to make such a meaningful advance in terms of the imaging of giant cell arteritis. I was looking at your track record of publications, and it seems like this is not the only thing that you've published on. In the past, it looks like you looked at empathic opportunities in medical dialogues. And while it's not the focus of this podcast, I am very much intrigued by this. How do you think that rheumatologists can integrate these cutting edge technologies, such as ultrasonography, with age old traditions of upholding empathy in the patient physician relationship?
It's funny that you mentioned that because my very first research project as a medical student was actually about empathic communication in medical encounters. We looked at how clinicians identify and respond to what we called empathic opportunities. You know, those little openings where the patient expresses worry, uncertainty, or vulnerability, and where the response from the clinician matters a lot. So I think about that work often because ultrasound actually creates many of those moments. When you do vascular ultrasound in GCA, you're sitting next to the patient, you're looking at the screen together, and you are literally showing them their disease in real time. That can be reassuring, but it can also be surprising or even intimidating for the patient, especially if they see something that they didn't expect. So I think how you communicate becomes incredibly important. Ultrasound isn't just a technical act, it's also a conversation. You have the opportunity to explain what you're seeing, to educate the patient, to check in with them, and to make sure they feel safe and understood. And often you get very immediate reactions from the patient, which give you a chance to respond empathically right there in the moment. So for me, the technology and the empathy actually belong together. The more advanced our tools become, I think the more important it is to use them in a way that still supports the patient and listens to their concerns and include them in what we're doing.
I could not agree any more. And that is deeply unfortunate because that is all the time we have today. I am very, very deeply grateful for your time and for your peace of mind. And it has been wonderful to see how you and your team members are empowering rheumatologists to better diagnose and manage this devastating and often overlooked condition. Also, from the bottom of my heart and my aorta as well, I would like to send a shout out to my colleagues at ARMS who are integrating ultrasound into their clinics in Europe, in America, and all over the world. It is fascinating to see the field develop and how it is enabling clinicians to be more nimble in their diagnostic skills. And as always, thank you all for listening to this podcast. We will see you all next time. ACR Journals on Air is a production of the American College of Rheumatology. Please follow at ACRheum on social media. Email us at podcast@rheumatology.org and rate and subscribe to our podcast at acrjournalsonair.org or wherever you get your podcasts. Take care.
This podcast was edited by Resonate Recordings.